wonderful panelists. Thank you. Adaptive care, how IT is revolutionizing the delivery of health care. We're going to follow the same format we did yesterday when we did panels. I'm going to ask our panelists to quickly introduce themselves, and then we're going to go right into the questions. And I'm going to come out into the audience, as we did. I want this to be very interactive. If I start walking near you, that means you should start to think of a very intelligent question to ask, okay? So let's start right out.
Just a little, that light is right in.
Sure, I'm Tom Judd, National Project Director for Clinical Technology in Kaiser Permanente, and what the heck does that mean? Well, I'm involved nationally with medical device integration work and had a previous history as a quality director for Kaiser here in Georgia.
Okay, I'm Jerry Glandon. I'm the chair of the Department of Health Services Administration at the University of Alabama at Birmingham. Health management program, but also has a health informatics master's program and a health information management undergraduate program. I guess that's a little bit on our background at this point. Long history in education, but started in consulting with a company you may know, Interqual Metaqual. So got exposed to the IT side on the quality measurement many years ago.
Good morning. I'm Janet Marchabroda. I'm currently, for the last year, been with the Bipartisan Policy Center. It's a think tank based in Washington, started by the former Senate Majority Leaders. We have a health project there and a big initiative on health IT. It's a bipartisan issue. Former Senate Majority Leaders Tom Daschle and Bill Frist, a Democrat and a Republican, share our work there, including our work on health IT. Let's see, some background. You know, what I'm going to share today, this topic is timely for us. We just released a report back on January 27th around new models of care, new delivery system reforms and payment reforms, and what health IT capabilities do we need to get there, and how do they compare to the trajectory that we're on in terms of policy. And so I look forward to this morning's discussion.
Hi, I'm Mark Woodward, EMC's healthcare CTO. I've spent my entire career in healthcare, both from kind of three lenses. Consulting, starting out, and then I worked for Partners Healthcare in Boston for about a dozen years, leading up their strategy and finances, as well as their program management office and innovation group. And then subsequently, as I like to say, kind of went to the dark side, over to the vendor side, and I've been there for about 6 years or so, and there I'm in charge of building new revenue streams for EMC, but also making sure that we kind of protect the future, as I like to call it with my guys, is to worry about things like the genomics world, the imaging world, the analytics world, not just about storage, which is where our core product is. We're really trying to foster new and developing platforms, let it be in the cloud or outside of the cloud, to foster new revenue streams for EMC.
Great, thank you. Would the panelists mind if I throw you a curveball? Okay. What's going to happen in June in that little building across from the Capitol? You know what I'm talking about? Okay, I thought you would.
The Supreme Court?
Mm-hmm. That little white little building, you know.
You want a prediction?
Yeah, absolutely. Absolutely. Predictions are free.
I heard the vote will be 5-4. So. I stole it, I'm sorry. Yeah. But you know more stuff.
You know, that's, it's hard to say. I think 6 months ago I would have said there was no chance that the health reform law would be repealed. I think now it's 5-4. I think it's just that close. The nature of the questioning. I mean, we're all looking at it from the outside. We don't really know it. One wonders why, for example, a severability clause wasn't put into the original law to begin with, just as part of a legal document. You know, I frankly have trouble imagining what happens, you know, how you unwind things that we've already started if we were to turn that back. And as many people have been saying in the popular press now, the ship has left the dock. a lot of the reform initiatives are going to continue whether we have a formal government initiative behind it or not. That kind of prognostication is really dangerous when it's in a body that we don't understand those internal markings out well. I mean, I would love to be a fly on the wall as they sit around and discuss sort of the precedent that they will set with this particular, if they overturn this, for example.
Great time to be a law clerk, huh?
I'm sorry?
A great time to be a law clerk.
Yes.
Assigned to one of the justices. Yes. What a great time to be a law clerk. I mean, basically makes your whole career involved. Janet, do you have any thoughts? Have you heard anything of Bill or Tom talking about that at all, and as you're a fly on their wall?
So we've been pretty quiet on this issue. We've got a whole event just following that around what's next based on the decision. I think, who knows? They say you can't really tell how it's going to come out based on the questioning. What's the likelihood of throwing it all out? I think it's pretty small. If anything, it's probably just striking down the individual mandate and then figuring out how the rest works. And I'm not a lawyer, and we've got folks at BPC that are analyzing this pretty carefully. But sort of bringing it back to our discussion this morning, what happens and what's the impact on health IT? It's fairly minimal, I think. There is some workforce-related stuff in there. I think the big piece for us, and what's important in the subject of this panel this morning, are the delivery system and payment reforms. I think there's bipartisan support, enormous support for changing the way we pay for health care and the way that we deliver health care. There's some differences in the approach and how one might do that. So that's the piece, I think, that will have the largest impact on us from a health IT perspective, if that goes away.
I'll add something to that in regards to the technology side of the conversation, is that as she said, the horse is out of the barn here. We've spent so much money in getting into the EMR space and getting digital in the healthcare industry that there's obviously lots of politics that go on in the White House and such, but that's not going to change as to what the effort has done. Everybody believes, both Republicans and Democrats, associated with digitizing the record and getting better information to the caretaker. And so the politics of the accountable care and how we go all about that, that's still out there as to a variable, but fundamentally the infrastructure behind it is still going to go on. And there's just no way you can, the economic model of healthcare cannot survive without changing the infrastructure technology behind it.
Barry, if I might just say one quick thing. While all of us in the room know that Hightech and ACA are different, believe it or not, there are a ton of folks, particularly doctors, that believe that the Hightech money and the 27 billion or whatever number that you use is really part of ACA. And so I think it's important for all of us to explain how they're different. Believe it or not, it's still out there.
Sorry, we're going to talk over each other the whole hour here, I think. If I can step back just a little bit, if you think about why we have technology and why there's this movement toward technology, we don't adopt it for technology's sake. It's really a means to an end. There's socioeconomic and political drivers that are inducing us to try and use technology to improve the quality and control costs for care. If you go back to the 2001 IOM report, which pointed out that quality perhaps wasn't as good in this country as we thought, and actually gave us some ideas as to why. The lack of communication, continuity of care, all of the things that IT helps to solve. And in fact, I like to be the gray hair, the old man on the podium. If you go back even further, if you might remember, there was a book by Jeff Goldsmith called Can Hospitals Survive? In which he postulated that in the near future, hospitals would be just glorified ICUs, and all of the care would be, or most all care beyond ICU care, would be done in a distributed fashion in people's homes, in physicians' offices, and others. So he was actually seeing the technology transforming healthcare. He published that in 1981. That's sort of when I sort of got interested in healthcare, and I kept thinking, okay, when's this going to happen? When's this going to happen? And I've been waiting, what's that, 31 years now. It didn't happen in the time frame I think that he thought, but if you think about what's happening right now, that's why the ship has left. We're now introduced incentive systems that say, we're going to be better off as delivery organizations if we can improve quality. We're being rewarded for better quality. That hasn't been the case in the past. Increasingly, we're getting rewarded for at least controlling cost of care. We tried that in the 70s with managed care. It didn't work quite the way we thought. But so we're really seeing part of a larger trend that is just going to unfold no matter what happens, in my opinion.
As the former naval officer, I love the ship. Left the dock better. But, I mean, I humbly represent a big organization, Kaiser Permanente, that, WOW has invested a lot in infrastructure and health IT, as many of you know. And, we've got some pretty good results going. So we've got a platform that we really want to build on for all these, myriad of issues coming up. So, yes, but reimbursement matters. So we'll see.
What's a high-performance health system? And how's it related to meaningful use?
I can start off the discussion on that. We actually, in this report, did a review of the literature, research around identifying high-performing healthcare systems, and identified the common attributes of those organizations. And just to tee things off, we looked at things like leadership at the top to bottom, vision, clinicians involved in decision-making in the organization, an organization-wide focus on the patient, and actually Kaiser Permanente was one of the ones that we identified and profiled in our study. Organization-wide focus on the patient, access to information, of course, by all members of the care team and by the patients themselves. Focus on timely access to care, and I know Kaiser's done a lot of good work in that area, enabling folks to get anytime access between visits, secure messaging and the like, and I know that's part of proposed menu stage 2. And then also focus on prevention and wellness. And so those are some of the things, the common attributes across those organizations. And so the question is, if that's what we need to do, if that's what we need to get to high performance, what health IT capabilities do we need to get there? And how do those compare with the gazillions of dollars of investments that we're making today? So it'd be fun to talk about that a little bit.
I guess, one of the notions of high performance would be not just doing your narrowly defined role well, but expanding that role to include, broader definitions of health of populations as opposed to health of the patient that shows up at your doorstep. So a high performance organization would be treating patients before they get ill, on the wellness, as you bring up. Pre-care, hospitalization would be good, post-hospital care, and follow-up. And it's that whole continuum that is going to be essential for high performance. I mean, that's what you see in other countries that have a better network, that are dealing more with providing the right mix of care as opposed to doing high-tech clinical care in a silo, essentially. We just did a visit in Barcelona looking at the Spanish system, and it was amazing. They spend about a third of what we spend, don't have access to a lot of the cutting-edge technologies for transplant. I mean, they do transplants, but it isn't readily available. But what they have is a great network and a great communication system to provide ambulatory care, their infant mortality rate is about half of ours.